Okay, so good evening from India here. Good afternoon and good morning to everybody, including our faculty members from across the world. Myself, Dr. Mohit Bhandari, and my mentor, my teacher, Professor Phoebe. We welcome you for this 25th and very welcome episode of Virtual Bariatric University, which we are again starting after a gap of 1.5 months because of a very, very severe wave of COVID-19 pandemic, the second wave here in our country. God has been great, and we are so lucky that the numbers are drastically falling here in India. And because of Almighty, all of us here in the country are back here spreading knowledge and interacting with a stellar group of faculty again on this virtual bariatric university platform created to disseminate the knowledge, skills, opinions of thought leaders from across the world created by Professor Phoebe and myself. Today we have a very interesting topic, the BPD-DS and the SADI-S as a bariatric metabolic operation. One of the operations which is really dreaded in India for the fear of malnutrition, for the fear of more than 100% access weight loss, and for the fear of liver failures. But we have one of the most experienced faculty members here today to throw light on many aspects about the common channel, the limb lengths, and about the benefits of this very unique and very powerful procedure, I would say. Let me start off by welcoming Professor Rosalind Michel from United States of America. Ms. Rosalind is Professor of Surgery at Barbara and Donald Zucker School of Medicine. He's the Director of Bariatric and Metabolic Surgery at Lenox Hill Hospital in New York and North Westchester Hospital in Mount Kisco. He gave the keynote address just last week in the Canadian Association of Bariatric Physicians and Surgeons, speaking at the ASMBS. He also did a course for IRCAD in advances in surgery, and the most recent publication include the impact of BMI on COVID-19 outcomes in obesity and a review article in Current Reports in Cardiology. This is one of the most relevant topics in the present times. His research interest area is impact of glucose variability on bariatric procedures, metabolomics, and the microbiome. Welcome, Mish. I know you published a lot about the limb lengths and its impact on various bariatric metabolic operations. And whenever myself and Professor Phoebe, we discuss about these limb lengths, he always mentions your name on the forefront. And he says, and he believes that your research is landmark and is going to help us all learn about this metabolic role of the limb lengths. Is it too much talked about, or it is too hyper rated, or it is something which is just a scientific concept? So welcome, Mish, welcome to the show. And I'm so honored to have you here. Next, we have Professor Rudolf Weiner. He just sent a message that he would be late to join us because he's stuck in a traffic jam. But Professor Weiner is from Germany. Everybody knows him. He's from University of Frankfurt and a senior consultant in metabolic and bariatric surgery in Offenbach in Germany. He was the founder organizer of the Great Frankfurter Meeting, which is now organized by his daughter and my great friend Sylvia. And I've been a faculty in that course and a live operating surgeon for last 5 years. It's a great meeting. I think all of us on the panel would have attended one or the other meetings as a faculty member. And we know that Professor Weiner has contributed so much, not only as the past president of IFSO, but as a board to this great organization and to the great field of bariatric metabolic surgery. He's also the founder of German Society for Bariatric Surgery, the president of the IFSO European chapter, the IFSO president, the president of the IFSO World Congress 2011 in Hamburg. Next, we have another great colleague, friend, and a very respected member of this bariatric community from Brazil. It's an honor to have Professor Sergio Santoro from Brazil, graduated and post-graduated from Sao Paulo, Brazil, and doing this bariatric metabolic surgery since 2002. And now is a proponent of new concept like a pure metabolic surgery, no mechanical restriction, neither malabsorption, just a functional restriction, and also a proponent of the procedure of transit bipartition, which I have a keen interest in that procedure these days, as I'm seeing some of my old cases, which I did like 3 years back, doing so pretty well with great resolution of diabetes. So my experience is very less in transit bipartition, but I would be so honored to listen to Sergio today and understand as to what are his concepts about this metabolic procedure, about bipartition, and also about SADI and BPD-DS. Welcome, Sergio. We have Professor Andres Panu from Spain. He's the head of upper GI Department of Surgery in Hospital San Carlos, Madrid, Spain, professor of surgery at the Complutense University in Madrid, Spain. He's a staff physician, Department of Surgery in Hospital Clínico San Carlos in Madrid. His main experience and interest area is in esophagectomy, gastrectomy, esophageal motor diseases, GERD, and bariatric surgery. He does gastrectomies, esophagectomies, but more are his anti-reflux operations and eclasia operations, and more than 150 bariatric procedures in a year, where he does almost 60 SADIs and 60 sleeves, some Roux-en-Y's and some revision procedures. Also, a surgeon who is doing colorectal hernia and thyroid. So immense amount of experience, Andre, and we are so honored to have you here on the show. Welcome to the show. We have Professor Lauren Beartho from Canada. Lauren is a clinical professor of surgery at Laval University, is an associate professor of surgery at Laval University, introduced the minimally invasive bariatric metabolic surgery at the Institut Université de Cardiologie in Quebec. He is a director of fellowship program in bariatric metabolic surgery at Laval University and the co-director and the research chair in bariatric metabolic surgery. He's also the past president of the Canadian Association of Bariatric Physicians and Surgeons. Welcome, Lauren, to the virtual Bariatric University. I think you have been probably one of the first Canadian to be on the show. A warm welcome to you.
Thank you.
We have Professor Marco Raffaelli from Italy. Marco is professor of surgery from University Cattolica in Rome in Italy. He is the head of division of endocrine and metabolic surgery at the Polisinio University Hospital in Italy. As a board member of Italian Society of Bariatric and Metabolic Surgery, is a coordinator of master's degree in bariatric metabolic surgery in Rome and Italy, and is a consultant member on the Commission of Obesity and Metabolism. Welcome, Marco, to the virtual Bariatric University. This is an honor to have you here, and we look forward to have your opinions and comments on the procedures and on the lectures. It's an honor and a privilege and a proud moment for me to have my own friend, one of the fellow Indian colleague bariatric surgeon, Amar Venupusa from India. Amar is a chief consultant, metabolic and bariatric surgeon, working at Dr. Amar Bariatric and Metabolic Center in Jubilee Hills in Hyderabad in India. He's a fellow of National Board of Minimal Access Surgery and have been performing bariatric surgery since almost 15 years now, focused into loop DS for obesity and diabetes. He mainly performs SADI-S and SADI loop gastroileal bypasses. And I think his data, as Professor Phoebe said, will help us learn more about how Indian patients behave with this sort of a long bypass with such a short common channel. Welcome, Amar. It's an honor to have you.
Thank you.
Again, from the side of our clinical director, Professor Phoebe from Mohawk Hospital, and from my side, I welcome all of you. And I also thank God to have us back again after such a major blow to our country. And the cases are decreasing and we are back with our bariatric program. Also, just to make an announcement, our bariatric program has started in full flow, and such a great opportunity in last 14 days. We We performed more than 50 bariatric procedures. So is the flow, and so has been the improvement of COVID-19 crisis here in the country. Welcome again. At this point, I think Professor Rudy has not joined us, but Marco and Sergio are here on the panel. I would like to invite them to moderate the lecture session. Marco and Sergio, the stage is yours.
While they're waiting, since Rudolph is not here, I would invite Dr. Pietro from University of Laval, Canada, where he's professor of surgery and chief of the bariatric program, to present his talk on SADI as a bariatric operation. Laurent, go ahead.
Thank you. So here we go, sharing my screen. So good morning or good evening, everyone. My name is Laurent Bertha. I'm a surgeon from Quebec, and I'm working at the Laval Institute, which is one of the largest center for standard biliopancreatic diversion. This is my slide for case mixed disclosure. As you see, half is sleeve, and the purple is DS, and this is Huawei, and this is loop DS. No disclosure really relevant to this talk. And this is our objective. So I just like to give you an idea of what's the place right now of DS and loop DS worldwide. My understanding of the physiological changes of DS, give you the idea of what we can get from a standard DS in terms of long term. We've been doing DS for the last 30 years, more than 30 years. So that's one of the surgery with the longest experience, and discuss also the place of second stage DS. So why should we consider doing a switch? In North America, my patient have a mean BMI of 52. So DS gives the best weight loss long term, and is being proven with randomized control trial. This is a trial from Dr. Jovic, who showed in a randomized trial 20% difference in excess weight loss in patients with a BMI above 50 compared to Huawei gastric bypass. Dr. Prashant also showed the superior resolution of metabolic syndrome, better control of diabetes, no post-gastrostomy syndrome, patient have minimal restriction, and really the place now of duodenal switch has changed in the last 10 years with the sleeve, is getting more and more interest as a staged procedure in a high-risk, high BMI patient. However, you see here 2018, that's the last report from IFSO, and they have removed, usually we had this 1% of DS who was at the bottom here. Now it's been completely replaced, and you see sleeve has taken the lead. Huawei has decreased, Huawei yes has decreased, that's one anastomosis gastric bypass that's increased, and basically the volume has increased. But the place of primary DS has been for the last 30 years at about 1%. Now, will it change with the SADI and the stage approach? We don't know yet, but it seems that there is an increased trend in revisional surgery, especially in the US after failed sleeve. So why is it so low, the DS and the SADI? So technical difficulty, I think the experience has improved. The technical experience of a surgeon has improved in laparoscopic surgery. There is increased side effects, but really the problem in the risk of nutritional deficiencies, risk of protein and lipid soluble vitamins. And that's really the place where SADI, I think, will play an increasing role as a potential solution to decrease this rate of protein and vitamin malnutrition. So in terms what I'm calling as a standard DS, so you have a picture here. So this is the sleeve, this is the alimentary limb, strict alimentary limb, and this is the common channel. Common channel is 100 centimeter, alimentary limb is 150 centimeter. They all have a specific role. So stomach is larger than what we do for a standard standalone sleeve. It's larger, but it's not, as we were discussing, it's not just like lipid malabsorption surgery. It's like a combination of everything. The stomach, there is a decrease in ghrelin, decrease in volume, decrease in pepsin from the stomach. The common channel is where we have a strong hormonal effect from the GLP-1, increased GLP-1. That's also where lipid and carbohydrates are mostly absorbed from the mix of food and biliopancreatic juices. There is increasing science from bile turnover, increased bile acids, increased change in microbiota. So all those mixes together. And in the standard DS, there is also a strict alimentary limb that's here to prevent bile reflux that you don't get in SADI, but also where you can have some absorption from carbohydrates from the amylase in the brush border, but also absorption from non-soluble vitamins, mineral, oligoelements, and also some protein absorption from the pepsin from the stomach. So all those play together and produce what we'll see as effect from DS. So as I was saying, DS was developed from Picard Marceau and Simon Biron back in 1989. So we have a series of, now we are slightly above 5,000 DS that have been followed for the last 30 years. We've been doing more and more Huawei, and sleeve is now increasing also. So this is not our 10-year or 15-year, this is our 20 years experience with DS. So a series of 3,500 patients, and you see that the weight loss is really profound and maintained. We have a 20 points of BMI lost from 51 down to 30. In terms of kilogram, it's 55 kilograms weight loss. So that's very efficient, and you see compared to other surgery, you have less of that weight regain that you see after other surgery. This is if you were to compare from the SOS study, 2,000 patients in the control group, 2,000 patients from the surgical group. You see at 20 years, we are at about 40% weight loss. Huawei is about at between 25 and 30%. So very effective surgery. Also extremely effective for type 2 diabetes. This is a series of 900 patients with type 2 diabetes. Overall remission is about 90%. And if you look at patients who are on insulin, typically after a sleeve or Huawei gastric bypass, you get 20% remission at 5 years and 10 years. We had a recent publication from Mingroni who showed very low remission, but still good control. But you can get almost 80% remission. That's a mean follow-up of 7 years. And we published our data at 10 years on type 2 diabetes on insulin. And this is, we were still at 70% remission for patients specifically on insulin. So extremely efficient in terms of weight loss and control of comorbidities. However, this is the side effects that you get from the DS. Foul-smelling stools, loose stools. 30% of the patient complain of loose stools, need some treatment. Mean number of stools per day is 3, from usually 1 to 2. You get some increase in number of stools. This can be controlled, but this is probably the most feared the rate of albumin over under 30. Between 30 and 35, usually it's just increased protein, powders, enzymes. Under 30, they need usually some more active treatment. And about 1% in our experience of the patient who will present with severe protein malnutrition, which is under 1%. 5% will need some readmission to treat that problem. And in our experience, again, that's a series of 3,700 patients. We had to reoperate on less than 2%. either feeding jejunostomy, increasing the common channel, or a complete reversal. So yes, it's there. It needs some follow-up. It needs some experience with this problem, but it's still low, and that's why we still have a. I think there is still a good place for DS in the bariatric armamentarium. Now, as I was saying, DS has increased more and more as a stage procedure. So this is our experience, early experience. We enrolled all patients who had the staged DS, 60 patients, 59, and matched them with patients who had the single stage DS for age, sex, BMI. And we wanted patients who had a minimal follow-up of 2 years. So we wanted to see at least what the surgery was doing for weight loss and comorbidities. So initial BMI was 54, 53, 54 in each group. So they were matched for this. And this is the weight loss, excess weight loss after the second stage. So you see patient after a sleeve had a mean 39% excess weight loss. And was quite reassuring because the weight loss increased back to 81, which is what we get. That was 6 years after standard DS. You see that the two curves really get together. So again, showing the effectiveness of DS, even in patients who had a failed sleeve. Complication for stage DS was 5% in both groups, actually. And this was the late complication at about 10 to 8.5 to 11% after both procedure. In terms of rate of remission of comorbidities, again, very reassuring because we had the same, very similar remission rate for type 2 diabetes in general. And the patients who were on insulin, that's not a big number, but still we increased our remission rate to 80%, which is what we see usually after a standard DS. So in conclusion, yes, it's the most effective surgery. I think we have enough data to show that in high BMI patients in terms of weight loss, correction of metabolic syndrome, especially type 2 diabetes. That comes to the cost of a higher degree of GI side effects and also a higher rate of protein and vitamin malnutrition. Still, I didn't show you the data, but patients get an excellent quality of life from especially the weight loss. Second stage DS data right now are quite reassuring. We get very good excess weight loss and remission of comorbidity similar to one stage DS. And that gives the opportunity to select the patient and assess compliance of patients. And thank you. This is to give you an idea of my group. So this is mostly nutritionists, nurses, psychologists, and so that takes a whole village to make this kind of program work. Thank you.
Thank you very much, Laurent, for the excellent presentation and summary of the large experience that only you in Quebec can present at this time.
Thank you.
I see that the only comment I'll make is that there seems to be greater acceptance of this procedure now that more doctors are getting better versed in using laparoscopic surgery.
Mm-hmm.
First, it was the difficulty of the procedure that was the inhibiting factor. And now that most of your publications are showing less than previously perceived incidence of protein malnutrition, more and more doctors are looking at this procedure. I have two questions that is more enlightening than pertaining to your operation. One of the biggest problems for the sleeve that is most commonly done worldwide now is the problem of reflux.
Mm-hmm.
And it's about the most common cause next to weight regain for revision. What has been your incidence of reflux with the sleeve that you do with the BPD-DS?
That's an excellent question. I don't have hard data on this yet. I would say we don't have that experience of bad reflux. About 30% of the patient will have some PPI on and off, but we take out the whole bile from the refluxate. So we have much less acid, no bile. So it's not the same surgery as and the sleeve is much larger. Typically, back in the 90s, they were keeping the whole antrum also. So all this doesn't make the DS a reflux creating procedure as the sleeve is. We, out of the 5,000 patients, I would say we had about 20 patients who had like either hiatal hernia repair, it's some anti-reflux procedure, and I think 3 patients who were converted to Huawei gastric bypass for reflux. So very well controlled with PPI usually.
So from what you've presented, would that be correct to say the problem of reflux in the sleeve is bile reflux rather than just reflux?
Good question. I think it's a mix of the size of the sleeve also. If it's a tight sleeve and increased pressure in the esophagus, so maybe some esophageal dysmotility. Some data show also some bile reflux, yes, and also taking out the whole antrum. Sometimes we get tighter and tighter to the pylorus, which we don't do in DS. So I think it's a mix of everything. I think there is also acid reflux in the sleeve itself.
Dr. Fobi, can I make a comment?
Sure, and the other panelists can make a comment after.
Sure. I think that we tend to separate reflux and weight regain in the sleeve, and I think that's an error, because the reason so many obese people have reflux is increased intra-abdominal pressure. And I'll talk more about this when we talk about staging. So one of the advantages that operations like the DS have, or SADI, or for that matter, one anastomosis gastric bypass, is you don't see as much weight regain. So I think a lot of times what happens is the sleeve itself is a high-pressured system, and then you add weight regain to it, and you're increasing intra-abdominal pressure. And I think it's a real mistake in a lot of people to just treat the reflux and not treat the weight regain, because intra-abdominal pressure rising from the weight regain in sleep. So I don't think those are two unrelated issues. I think they're very much related. And sometimes people will eat more to basically buffer the reflux that they're feeling. Yes, it's a bile problem. Yes, it's an acid problem, but it's also a weight regain and intra-abdominal pressure elevation problem. And the worst reflux you see after sleeve is patients that get tummy tucks.
I would like to comment, if I may.
Go ahead, please.
Well, I totally agree with Mitch. Weight regain is really a problem, but the tighter the sleeve, sometimes they damage the link fibers of the sphincter. So there is, in the tight sleeves, there is also damage of the sphincter. But I would like to make 2 questions for Dr. Biertot. First, I would like to congratulate him. We first met in Canada, in Quebec, and I congratulate for his lifelong dedication to this issue. He's really an authority in this field, and I really appreciate. But I started my life with treating short bowel syndrome, and I always saw malabsorption as a really bad disease. And it really scared me that a disease could be used to obtain weight loss, which is one of the symptoms of the short bowel syndrome. But time has passed, and today we understand the surgeries as much more metabolic than dependent on malabsorption. So I have 2 questions for Dr. Biertot. First, how much do you think malabsorption is important for your surgery? Or is it basically a metabolic surgery that happens to have a malabsorption? And the second question is more physiological, because GLP-1 was the great star over these years. But recently, we understood that FGF19 is really a very important hormone, maybe as important as GLP-1. And FGF19 is just secreted by the mucosa of the ileum when in the presence of bile. So when we understood that, we rapidly enhanced the common channel of our transit bipartitions, and we noticed that we didn't lose anything, we just gained. So I would like to understand, if you do a duodenal switch, there is a long part of ileum that there is no bile inside. So because of this metabolic issue, and because of malabsorption is a nasty disease, I tend to understand that the very long common channel, especially if 100% is a common channel, it would be physiologically superior because of FGF19, and also superior to this from the patient standpoint, because he would get rid at least of great part of the malabsorption. I would like to hear, Laurent, your vision on that.
So again, that's very complex question. In short, I would say, yeah, I did a very interesting study with Michel Gagné back 10 years ago, where we were collecting stools after bypass and BPD. So I was in charge of getting the patient collecting, you can imagine, the stool buckets. So in terms of fat, that's very basic question, but yes, there is about 80% of the fat that's malabsorbed. So I think it plays a role. I think in patient, we are not machines, so patient can sometimes eat more fat. They will get a lot of side effects from this. But again, they will lose those calories. But I think the main effect is, yes, it's metabolic and it's hormonal, it's neurohormonal. It's the effect of gut brains on the appetite centers. And you said GLP-1, the IGF-BP2, all the hormonal factors. So now, in terms of the length of the common channel, we've had a lot of iteration from 100 to 200. Sometime now with the SADI, we go to 250, 300. Our experience is the more you increase the common channel, the more absorption you get. So when we have a patient, for example, with a protein or malnutrition, we increase the common channel from 100 to 200 centimeter, and they typically regain about 10 kilograms as a mean, but also that correct the protein malnutrition. So, but that's not only for the protein intake, that's also hormonal effect. So it's a very complex question. But my experience, we've been going with this surgery because I don't mean to say that every patient need a BPD-DS, but when you are at BMI 50, 60 and higher, I think you need some very strong procedure, and I think you have one chance to go. So I'd rather patient, even with protein or fat malabsorption, when we tell them about reversing the surgery, they would say, no way, I would rather keep with low protein, vitamins, and so on, instead of regaining 10, 20, 30 kilograms. So you see, that's 50 to 60 kilogram weight loss on the long term. So I think obesity is probably the most severe disease and the most disabling disease we have right now.
Okay, Marco, go on to the next session, and then we will.
Can I ask a question to Dr. Bietro? It is evident from your experience that stage and single-step procedure are the same results, and sometimes the results of stage procedure are even better with respect to the standard duodenal switch. So is this evidence change your attitude? I mean, is there any group of patients in which you suggest by the beginning a stage procedure?
It's changed a lot. The sleeve has changed a lot. When I arrived here, it's already like 15 years ago, I introduced the laparoscopic approach. And before that, every patient that was coming, BMI 35, 40, 50, 60 anyway, they were getting a DS. They were getting a open BPD-DS. So the experience has changed a lot. And yes, we get more and more. Now we do 50 to 60% of sleeves that allow us to get higher volume, offer something to the patient. Patient ask more and more for the sleeve, and that's allow us also to check, to assess the compliance with the vitamins, with the follow-up. If we have a patient who has a sleeve and who doesn't show up for the follow-up, or after 2 years come back with weight regain, or 3 years with weight regain, that's not a good candidate for a DS.
Okay, thank you. So there is a little place for primary duodenal switch.
Yeah. Oh, yeah, sure. Yeah, definitely.
Very
For a good
clear.
patient, BMI with metabolic disease or BMI 50 and above, I think that's the best surgery. Yeah, definitely.
And probably also in those patients, it's better to start with the sleeve and then second stage.
Well, it's 2 surgeries. You add the surgery, you add the 2 procedure for what benefit. If it's a good patient and doesn't want to go through all the process to anesthesia and so on, I think in our experience, I think yes, it's still reasonable.
Thank you.
Sure.
Now,
Okay, go ahead.
it's for me a privilege to this bariatric and metabolic operation. Please, Andres.
Thank you very much, Marco, and thank you all. Thank you all, because for me it's a real pleasure to be here with you all. I've been asked to present the results on SADI-S, the long-term results on SADI-S. So I will try to present you an update on the operation and the long-term results that we have observed. These are my disclosures. You'll know that SADI-S was born as the gathering of 2 different operations. The one, anastomosis gastric bypass, performed first in 1997 by Robert Rutledge, and the U&Y duodenal switch performed first by Doug Hess in 1988. So putting together those operations, what means eliminating the whole limb of the U&Y duodenal switch, was born the SADI or SADI-S in 2007 in our hospital. SADI-S has some advantages when compared with one of the original techniques, which is the one anastomosis gastric bypass, as the pylorus is preserved. Not only the pylorus is preserved, but its vascularization and its innervation, so the pylorus is functioning after the operation. And the other advantage when compared to the one anastomosis gastric bypass is the exact knowledge of the absorptive capacity of the patient, because we always know the length of the common limb. Well, initially, as it has been said, we performed studies with a common limb of 2 meters. And our initial results were very good, because our patients had an excess weight loss of 100% in the first 2 years. But on the other hand, we had a 14% recurrent hypoproteinemia that led these patients to undergo a new operation. So from 2009 to present days, we have changed, and we introduced initially the studies with a 250 centimeters common limb. And for some occasions, we also have worked on the 3 meters operation. Our long-term 5-year excess weight loss has gone down to 87%, which is a very good number, I think, and recurrent hypoproteinemia has gone down to 2.5%, and it's improving over the years. No patient with SADI-S 300 has ever been submitted to reoperation. So I will consider the following points. This study is the definitive substitute of the duodenal switch, and for that I will present weight loss results and metabolic results, but also post-operative complications and the nutritional issues we have talked about after the duodenal switch. I will comment some technical details for a safe operation. We'll make a commentary also on if it should be performed in 1 or 2 steps, and I will tell you about my idea of the current indication, or which is the ideal patient for SADI-S. To demonstrate that the SADI-S is the definitive substitute of the duodenal switch, we have to demonstrate comparable weight loss results, comparable metabolic results, and at least a comparable quality of life, if not better, than after the duodenal switch. For that, I will present you the series of patients with at least 5 years of follow-up completed. Patients were operated between May 2007 and December 2015. There were 199 patients, but I will discard 35 patients submitted to SADI as a second step for weight regain or as a program second step after sleeve gastrectomy. So it leaves 164 primary SADI-S patients operated, which represents about 20% of our case mix. The mean age of this series was 47 years, mean initial weight 124, mean BMI 46. There were more women in this series. Diabetes was present in 61% of the patients, half and half insulin or oral therapy. Hypertension was present in 55%, obstructive apnea in 50%, and dyslipidemia in 72%. The first 50 patients were submitted to SADI-S 200, then the technique was abandoned, and 99 patients were submitted to SADI-S with a 257 centimeters common limb, and 15 patients underwent SADI-S with a 3-meter common limb, the American version. The anastomosis was mainly stapled because the first anastomosis during our learning curve were stapled. Then we moved on to the Hansun anastomosis, which is our standard technique today. These are the post-op complications. One patient suffered from a gastric staple line leak treated with a drain. 2 patients suffered from duodenoileostomy leaks, one reoperated and one was treated conservatively. 1 patient suffered an intestinal perforation and was reoperated. 2 patients had an incarcerated hernia, trochal site or epigastric. 1 patient had a gastric bleeding and was submitted to upper GI endoscopy. And 2 patients had an intra-abdominal bleeding and needed further surgery for that. There were no deaths in this series, and 23 patients, what means 14%, came back to the emergency ward in the first post-op month. 5 patients, what means 3% of the whole series, need readmission. The follow-up demonstrates that 84% of our patients were followed for 5 years, and 75% of our patients were followed for 10 years, what represents 60 patients out of 80 patients completing 10 years post-operatively. And this is the graphic representation of what I've just said. The excess weight loss at 5 years was 87%, and it dropped to 80% at 10 years from surgery, for a total weight loss of 34.4%. And we had some failures, and the number is 10% at 10 years. Patients needed lifelong supplementation, mainly with vitamin D and calcium, but also with iron and some other vitamins and micronutrients. And in spite of this, we saw deficiencies in the lab tests. Although patients improved at 10 years when compared to 5 years evaluation, you see that at 10 years, still we had abnormally low levels of vitamin D in 60% of our patients, and abnormally high numbers of parathormone in 70% of our patients, and that is our Achilles heel of this operation. Diabetes improved after surgery, and numbers are quite close to those reported by Laurent Bierthaud with the duodenal switch. Mean glycemia preoperatively was 170 milligrams per deciliter, and it dropped to 104 at 5 years and to 117 at 10 years from surgery. A1C was 7.69% preoperatively, and it dropped to 5.5% at 5 years and 5.8% at 10 years from surgery. It's more impressive seeing that preoperatively, only 11% of our patients were under no therapy for diabetes, and at 10 years from surgery, 61% of them are with no therapy for diabetes, 27% are under oral therapy, and only 11% are still with some low dosages of insulin, while at preoperatively, 41% of them needed insulin. And here is the graphic representation of what I've just said. And this is the representation of the evolution of glycemia and A1C after surgery, as you see. Hypertension did also very well, with only 14% of the patients with hypertension at 10 years, and 2.1% remain with obstructive apnea at 10 years from surgery. This lipidemia went a bit worse, and perhaps if we compare this data with those of the standard worldwide donor switch are a bit worse, as 53% of our patients had some abnormality in lipid tests at 10 years from surgery. Talking about the quality of life and reoperations, we have to speak of daily bowel movements. And as you see, at 5 years from surgery, our patients have a mean number of 2.4, and at 10 years, this goes down to 2.1 daily bowel movements at 10 years. Reoperations were needed, and let me here consider the whole series, in 7.1% of our patients, mainly because of malnutrition, but some patients were reoperated for weight regain, submitted to sleeve gastrectomy, 3 because of hiatal hernia, and 11 were submitted to gallbladder removal. If we compare these numbers with those reported by Luis in JAMA 2 years ago, you see that after one-way gastric bypass, it's reported 22% need of reoperation related to the first surgery, and after sleeve gastrectomy, 18%. For our numbers, I repeat, 7% in 10 years. So the operation is easier, is faster, and is simpler than the dural switch. And the group of Dan Curtam reported in this paper that we also cooperate with Mitch Roslin also, an anastomotic leak rate of 0.6%. And we include here the learning curve of all groups participating. But what is more important is that long-term problems of the anastomosis, as are strictures and ulcers, so frequently seen after one-way gastric bypass, are rarely seen after SADI-S. The operation has less malabsorptive power when compared to the dual switch, has less fat malabsorption, fewer intestinal movements, lower loss of fat-soluble vitamins, no problems with fluid electrolyte balance, and no urolithiasis. And when we compare weight loss with the original dual switch of Doug Hess, but I think these curves are similar to those that Laurent has shown us before. Here is our curve after SADI-S, after 10 years after the operation, which is quite comparable to those reported by Hess. Metabolic results have been reported to be slightly better than after the worldwide donor switch. Why? Because it has been spoken by Sergio before. The longer common channel leads to a long contact time of bile salts with the L cell surface. So there is going to be a higher stimuli to TGR5 receptors. And so a higher GLP-1 secretion is expected. And so a better glycemic control. And this has been smartly demonstrated by the group of Mario Nora and Sofia Pereira in Porto, in Portugal. 2 technical details to perform a safe operation are to leave a wide sleeve gastrectomy, to leave the antrum to help with the intake, and to dissect a long duodenal cuff down even to the bile duct to warrant that the anastomosis is performed safely and comfortable, so a low rate of post-op complications is expected. We like to preserve vascularization and innervation. If we divide the right gastric artery many times, nerves to the lesser curve are going to be divided also, so the pylorus is expected to have problems with functioning. So I personally prefer to leave those nerves and those arteries untouched. And as I told you, I prefer to do a long duodenal dissection, at least 2 to 4 centimeters, and open a wide window to introduce the stapler. Our patients initiate oral intake at 6 hours. I discharge usually post-operative day 3, and are maintained on a liquid low-caloric diet for 1 month, insisting that the amount of proteins must be over 60 grams per day. After the 2nd month, food is sequentially introduced, and we ask our patients to have at least 1 gram per kilogram of weight of daily proteins. The fat intake must be reduced to less than 30% of the total caloric amount, or 20 grams per day, and we always supplement them from the beginning with iron, calcium citrate, vitamin D, vitamin A, and sometimes with other vitamins. Again, I present now you the comparison of 1 and 2 steps operation. First of all, we have reported twice that the operation behaves well as a second step operation. Recently in SWORD, we reported a 79% excess weight loss at 5 years from SADI as a reoperation for a failed sleeve or as a program second step. And when we compared in a matched series with studies performed in one shot, you see that there is no difference in the 2 procedures. Which are the current indications for the operation, or which is the ideal patient for me for SADI-S? Well, this patient could be ideal to perform in 2 steps, of course. We select patients above 35 years old and below 60, usually with a BMI 48 over 48. Especially we like metabolic patients, either with diabetes or dyslipidemia. Of course, the patient has to understand the procedure, has no liver disease except, of course, of fat liver disease, but discards cirrhosis, no bowel disease, inflammatory bowel disease, or irritable bowel disease, no addictions, talking about drugs or alcohol, and we should warrant the follow-up. Do we perform studies? Do we offer studies to all patients, and how? Well, if the patient is over 35 with a BMI between 46 and 55, we do studies with a 250 centimeters common limb in 1 shot. If the patient is difficult, either before the operation or in the during the operation, we find the patient is difficult, we do a 2-step approach, offering the second one at 9 to 15 months, although patients usually at this time refuse to undergo the second step. When the patient is below 45 of BMI with age below 35, we usually offer a sleeve and follow up. Except for the patients with severe metabolic disease, in those we offer studies with a limb length depending on age and BMI, but we recommend to undergo studies in spite of age or BMI. For AIDS patients with a low BMI, we can offer a 1Y gastric bypass or a SADI-S with a 3-meter common limb. As I feel more comfortable doing SADI-S, I prefer offering SADI-S 300 to this subset of patients. And what about the 1Y duodenal switch? Well, I think there is still a place for this operation, of course. If the patient has a high BMI and Barrett's esophagus, if we offer SADI-S, we could have some patients with an intentional provoked bile reflux. So in these patients, we recommend to do a 1Y duodenal switch because we warrant a 0 bile reflux, and bile reflux is one of the factors for the development of an esophageal cancer after Barrett's esophagus. And of course, if we, during the performing of the anastomosis, find there is tension at that point, O&Y will relieve this tension and will be a good option. So to conclude, after an appropriate selection of the candidate, after an adequate technical operation, and with an adequate follow-up and supplementation, I think SADI-S is a safe operation, it's an effective operation, as you see, with good long-term results, and it is an efficient operation because there's a low rate of long-term anastomotic complications requiring interventional endoscopy or surgery. Thank you very much, my friends.
Andres, thank you so much for this very comprehensive presentation on the results of SADI-S. I have to say that referring to your last slide, I don't agree that in patients with Barrett esophagus, the best choice is Roux-en-Y duodenal switch. Probably, in my opinion, it would be better, even if we are facing a super obese patient, a long limb Roux-en-Y gastric bypass. But what I would like to underline from make a comment of what you present is about the excellent results of SADI-S in terms of metabolic effect, especially in the control of diabetes, type 2 diabetes, very similar to those of bilipancreatic diversion with duodenal switch and the scopinaric procedures. What is important, in my opinion, acts very different from the Roux-en-Y gastric bypass, because in Roux-en-Y gastric bypass, we observe peak of insulin because usually it acts as an incretinic effect, while in biliopancreatic diversion, I've experienced with Scopinaro procedures, but it's the same for duodenal switch and for SADI-S, as I studied recently. We observe a restoration of insulin sensitivity. So following the operation, we have a flat curve, probably referring to what Dr. Santoro has already said, bypassing all the jejunum and reaching the ileum as a different effect on insulin secretion. So this is the most important things I observe as a metabolic procedure for SADI-S. And I would like also to ask a question about your standard candidate for single osmosis duodenal switch. Does the length of the channel, does the attitude one step or stage procedure change if you are facing fertile female patients?
Thank you, my friend, for your comments and for your question. Oh, the fertile patient the patient wanting to have children does not change our standard limb. Just say the girls' infertility programs that we have a lot, that in the moment they suspect they are possibly pregnant, they must speak with her endocrinologist even before telling her husband. It's the most important thing. I have not the data, but I will have in the short future. We have very few problems with the pregnancies of these patients. If the patient is committed in the follow-up and has this adequate supplementation, there should be no problem with that.
I have to say that I have to agree with your point of view. We have some patients after SADI-S that have a safe delivery. This was not true for the whole Scopinaro procedures, but I have no experience with the standard Roux-en-Y duodenal switch.
Mm-hmm.
Dr. Raffaelli mentioned something that I think it's really, really important. And probably in this table here, we all will agree. Ileal surgeries are completely different from surgeries that don't involve the ileum. Probably because of a restoration of insulin sensitivity. He very fastly, briefly mentioned it, but I think that this is a landmark in bariatric surgery because insulin resistance is in the root of probably most of the evils related to obesity and to the glycemic and lipidemic problems. So I have no doubt that surgeries that involve the ileum has a lot bigger chance of correcting the metabolic disturbances, both in obesity and diabetes. And I think that the solution for our bigger problems are around this table here and not properly with jejunal surgeries.
I agree with you, Sergio, because eliminating the jejunum from the root of the aliments seems to be very important in terms of carbohydrate absorption, but also in terms of GLP-1 stimulation, and probably we'll see in the future if your proposals about the farnesyl receptor are also true. But I also consider, and Mitch has a large experience on that the preservation of the functioning pylorus has an enormous importance in the control of the metabolic disease, of course. I think it's secondary to the regulation of the gastric emptying, but I'm not sure, and probably your experience with bipartition will tell us which is the real truth underlying this.
Well, indeed, both sphincters, the ileocecal valve and the pylorus, they were tributed to a greater part in the control of the emptying of the small bowel and the stomach. But what we saw in small bowel ileocecal valve resection and pylorus resection is exactly the same. They are not so important as we think, because it's the hormonal motility that is changed. So when you have the elevation of these distal gut hormones like PYY, GLP-1, which are the great breakers, the transit and the gastric emptying just ceases with or without the pylorus in it. And the same happened to the ileocecal valve. The preservation, Dr. Angelita Gama had done some work in preservation the ileocecal valve due to avoid diarrhea in those patients that lost the large portions of the gut. And you see that the ileocecal valve per se is not as important as the hormonal changes. We think that everything that we see is metabolic. This is what happened in Roux-en-Y gastric bypass also. They call that procedure malabsorptive. But for those that have the experience to work with the short bowel syndrome, we know that it's absolutely impossible to have some degree of important malabsorption just by passing 100 centimeters if you have 6 meters down. We that deal with short bowel, we know that the Roux-en-Y gastric bypass is a totally endocrine surgery. And I think that the same happens also to the SADI and to the duodenal switch. It's purely metabolic surgery. I think we don't need malabsorption at all.
Question, if I may ask to Andres, I'd be curious. I hear now people going to 350, 400 centimeter, like SADIs. What's your experience? You went from 200, 250, 300. Did you look at the data between the 300 and the 200?
Yes, thank you, Laurent. And I presented the results, the comparison last week in the SMBS, finding no significance because the numbers of SADI-S 300 is short, and the series of 200 was. But still, 200 and 250 works similarly. The difference is in the malnutrition rate. I mean, the long-term weight loss is quite similar at 10 years. With 300, we see that curves separate at 2 or 3 post-operative years. When we initiate 300, we perform the operation with the same bougie as 200 and 250, a 54 French bougie. Then we observed a worse weight loss, so we changed into a bougie of 42 French for the 300, but still I'm not happy with the results obtained. They are quite similar to those of Roux-en-Y gastric bypass. However, if I have to choose one or other operation, I think the preservation of the pylorus, in spite of what Sergio was telling us, is better. So I choose SADI-S 300. But usually my standard length is 250.
Thank you.
Okay, we'll move on with Sergio. You have to unmute yourself. Yeah.
Oh, I'm going to present Mitch, I suppose.
Yes.
Mitch is professor of surgery at the Barbara and Donald Zucker School of Medicine at Hofstra Northwell, director of bariatric and metabolic surgery at Lenox Hill Hospital in New York, and in Northern Westchester Hospital in Mount Kisco. And his recent publications include the impact of BMI on COVID outcomes and obesity, and review article in Current Reports in Cardiology. Well, we all know Mitch, his impressive work in this subject, and we are really willing to hear from him. Mitch.
Thank you, Sergio. Let me share my screen. And okay, as we go over here, and let's just go up and start show. Okay. Well, it's really an honor to be here, and having listened to the other talks, I think that I can provide a lot of try some things together. And I appreciate the kind introductions. Dr. Phoebe has been somebody I've looked up to for years in this field. I think what Mohit has accomplished in India is incredible. And obviously being on a panel with Santoro, Andres, and Laurent is certainly a great honor. Just some of my disclosures, which I don't think are relevant. And in terms of my bariatric experience, which I do think is relevant to this talk, is that I was actually the principal investigator of the RESTORE trial. I kind of believed in gastric bypass, and I grew up with gastric bypass. And then in the early 2000s, patients started coming back gaining weight. And again, it was simple to me. We're just going to need to make the outlet smaller because it's all mechanical. What I found is that what most of the patients were talking about was actually the result of hyperinsulinemic hypoglycemia. So I postulated that potentially preserving the pyloric valve would make an advantage, would be advantageous. And since that time, my practice has been kind of based on pyloric preserving operations, sleeve, first the Roux-en-Y duodenal switch, and then starting in about 2009, when I was doing a lot of bypass to DS revisions, began to do a single anastomosis version when Dr. Kadam and I led the US trial. Briefly, kind of what we've done in the US is, as Dr. Andres Sanchez Permuti was talking about, is our sleeve length is slightly smaller, generally done under a 42 bougie, and we preserve more intestine. But I'm going to talk a little about that. Well, the reason we're doing this virtually is the impact of COVID. Obviously, it hit New York, where I practiced last March. And people made the observation very early on that old people were really succumbing to the disease. And when people were younger, they tended to be obese or have metabolic syndrome. And I think that provides great insight, and it's really an important theme and begins to tie together what we're talking about, and especially what you're living through in India. And that is that when you have increased glucose, increased insulin, your physiologic age is much higher than your chronological age. So that a person who's 50 who's obese behaves like somebody who's 65. And actually, when you actually looked at the deaths in New York, the average BMI was actually less than the national average, but 40% of the people died from nursing homes. When you looked at the younger patients, they were very likely to be obese. And what it's really become clear is that glucose mixing with protein causes glycosylation. And the cause of increased aging is really a high insulin state, as Dr. Santoro was just alluding to. So that basically what happens is the furnace is turned on. And it's not just COVID. What we're seeing is epidemics of things like cataract. You would not relate cataract disease to being obese, but it's actually been found in a recent publication that bariatric surgery reduces the incidence of cataracts, and people who have cataracts at young age are more likely to have obesity and metabolic syndrome. Again, the rise of obesity as an epidemic and metabolic syndrome has caused an exacerbation in the number of cases of early dementia. One of the huge controversies in the United States is the approval of a drug for dementia that many people do not feel is very, very effective. But what is absolutely clear is that dementia, especially before the age of 80, is certainly linked to metabolic disease. So what really happens? What really happens is that what should happen when you're young and healthy is you should turn glucose into glycogen. And what happens when you become insulin resistant is you develop ectopic fat. And it probably begins at the level of the muscle, and within the muscle at the level of the mitochondria, where there's kind of a traffic jam. And what happens is that fat intracellularly drives insulin resistance. Insulin resistance basically causes metabolic inflexibility. The insulin rises. When insulin rises, that tells the liver, instead of making glycogen, to make fat. And this doesn't just happen in the liver. It happens in the pancreas. It happens in the brain. That basically, even in the level of the muscle, and when you have insulin resistance and high insulin levels, that is really the culprit. And about 85% of the people that we see have hyperinsulinemia way before they have any trouble in glucose. And we've been doing a lot of continuous glucose monitoring. So the real goal in treating bariatric disease has to be lowering the amount of insulin that's produced while maintaining euglycemia. And in fact, what you will see if you measure fasting insulins on your patients is that the loss of glucose control actually happens very late. The first thing we're going to do is we're going to try to make a lot more insulin. Dr. Sharma, who's, again, I think one of the leaders in our field, says that weight's like a rubber band. Because what happens when you lose weight is the body doesn't reward you. You have a process called adaptive thermogenesis. Your heart rate variability, which is a measure of your sympathetic and parasympathetic tone, goes down. You have decreased sympathetic tone and the body becomes more efficient. And this is really an answer to something that's really, really important. Exercise itself is not a great weight loss effort because it kind of drives the body to eat more. However, exercise following weight loss is the only way to maintain your weight loss because you need that sympathetic tone, almost like a saber-toothed tiger is chasing you, in order to lead to lasting weight loss. So we've all talked about the emerge of sleeve gastrectomy. So the question, and Dr. Sanchez-Permuti, as well as Laurent, have alluded to this, how effective is a sleeve gastrectomy? So this is some of our data, shows that, if your goal is to not be obese and your BMI is less than 40, 95% of people will get to a BMI less than 30, at least if they're native weight loss, when you perform a sleeve gastrectomy. However, if you go to a BMI of 50, you only have a 5% chance. And this is native weight loss. What happens when we do a sleeve gastrectomy is that we have a tremendous amount of adaptive thermogenesis. And when we add the intestinal conduit, what we see is two things. We see greater weight loss and lower recidivism. And that's something that I'm trying to understand why that happens. Is it a change in the microbiome? Is it all hormonal, as Santoro says? Is it the thermic effect of food? Is it because there's a continuous caloric reduction because of malabsorption? But when you add a lengthy intestinal conduit, your average weight loss goes up to 40%, and probably more important is it blunts the recidivism. So one of the things that I really want to do in the future is take our field more functional. I think that we spend more time looking at weight loss rather than function. And probably the best level of function is your VO2 max. And this is a portable machine that we've been given that I've begun to look at, sleeves and just beginning with DSs. And I think it's a great way to look at patients because if you have a VO2 max, you're determining whether they're healthy or not. But the first thing that we did is we looked at some of our sleeve patients at native weight. And then we compared their metabolic rate to the Harris-Benedict or whatever predictive scale that you meant. And on average, they're about 30% less than predicted. So 9 months, your metabolic rate goes down because you get smaller. But even if you account for age and sex following the sleeve gastrectomy, their metabolic rate is about 30% less than predicted. What does that tell you is that if they begin to eat slightly more, okay, they are doomed to regain weight. And I think that's really, really a very, very important point. Again, bariatric surgical procedures grew up, and we were talking about before we went live with the show, we were talking about the meeting in Quebec, which I estimate was in 1996. But, you know, prior to Dr. Atkins, the prevailing thought was that fat made you fat. And now we know that it's probably not fat, it's probably processed food. So when you begin to back away and you take away the tradition, the common channel is probably most important in the absorption of fat. Proteins, especially refined carbohydrates and processed foods, are probably going to be successfully absorbed in the rumen. So this allows us to expand our common channel, and what's exactly the right length remains to be seen. But I think it's really important that operations that grew up with the idea that you needed a very short common channel are probably based on the idea that fat made you fat. And I really don't think that's accurate at the present time. So as I mentioned, following the RESTORE trial, I became very, very interested in the concept of glucose variability, because what sounded to me is that my bypass patients were coming back because they would eat something, they'd get lightheaded, and what they do, they ate again because they became hungry when their glucose nadir. So essentially, we began to look at, and this is in Roux-en-Y duodenal switches, we began to look at duodenal switches, sleeve gastrectomies, and gastric bypass, and we did it with both solid and liquid challenges. And what we found is that gastric bypass caused hyperinsulinemia, hypoglycemia. The DS basically was euglycemic, and intermediary was sleeve gastrectomy. Now, is that due to the pylorus? Is that due to the fact that we generally make a larger sleeve in DS? Is it due to the intestinal bypass? These are things that we really have to figure out. But what I can tell you is that now with CGM, we've been able to really show this. So I talked a little about what happens when somebody's morbidly obese. At first, 85% of our patients are metabolically ill. They're going to raise their insulin level, become profoundly insulin resistant. And once your insulin is high, it's nearly impossible to lose fat. And that's what leads to ectopic fat in the liver. And then they lose glucose control. And this is a continuous glucose monitoring you'll obviously see of your morbidly obese male. Now, here is where it gets really impressive. This is the continuous glucose monitor of a patient that came back. Her mean hemoglobin A1C was in the normal range. Mean glucose was 93. She came back with weight regain following the gastric bypass. During the day, she doesn't eat very much, and then looked at the peaks and valleys of her glucose going up and down. And I think this begins to explain a lot of what happens in gastric bypass surgery to the average patient. And this is the extreme end of it. This is a patient that came with neuroglycopenia and passing out from gastric bypass. And this is a whole separate talk on how to treat this on its own, but I see a lot of patients. And what I have to tell you is that this may be an irreversible situation that actually can lead to damage of the enteric nervous system, leading to chronic dysphagia, as well as chronic constipation. And I've even seen bladder stimulators placed in these patients, as well as pacemakers. Interestingly, this is the curve that you will see following single anastomosis DS. So if what causes increased aging and the numerous medical problems that we have talked about, diabetes, yes, but even things like cataracts and dementia is a high insulin level and glycosylation that causes kind of what's called a Maillard reaction. That's what causes aging. And the Maillard reaction we talk about in steak, but that's what happens when protein meets glucose happens. Then what our real goal is to keep insulin levels down while controlling glucose in a more euglycemic way. In other words, reducing glucose variability. And this is a single anastomosis DS curve. Don't just believe me, but this is Dr. Torres and Andres' data. And on top, you have gastric bypass. And at the bottom, you have single anastomosis DS. They also went further than me, and they showed that this glucose variation actually correlated with recurrence in diabetes in gastric bypass patients. So I think that this is a very, very important point of that and where have I taken this, is that adaptive thermogenesis with sleeves is going to be very common. You have to add the intestinal conduit. And when you add the intestinal conduit, your goal should be to not have hyperinsulinemic hypoglycemia. And I think that's where I wanted to take the first portion of this case. Brief video, and again, not to show the technical aspects of the operation, but notice you want to have some antrum. You do not want to have the smallest sleeve with the biggest intestinal bypass. And one of the things that I don't think we spend too much time talking about mechanics and supplements, and we don't talk enough about the food people are eating. And I know we have an Indian audience, and people brought up the impact of vegetarians. And there's a craze in the United States with vegan diets, which is actually frozen. Let me just tell you that Coca-Cola and Doritos are both vegan foods, okay? Especially if they don't put any cheese in, and potato chips. The problem is processed food. And one of the things that you need to look at is the quality of the food. So these operations are absolutely fine if people are eating lentils, fresh food, legumes, proteins, basically foods that existed a long time ago. There is no good diet, okay, there is no good operation for the bad eater. And probably what really needs to be evaluated the most is the monetary ability of the patient. Because if they're going to be eating the cheapest junk foods, then an operation that adds an intestinal bypass, whether it's OAGB, SADI, SASI, a bipartition, is going to have numerous issues, especially when we begin to look at function. So again, not saying it really should be, but if your goal is to get to a normal BMI, which many of our patients want, when you add an intestinal conduit, in my hands 3 meters, I take that number from most patients having to have a BMI of less than 45 to reach a BMI of less than 30. I take it to the 50 to 55 range, where people will lose on average about 17 to 18 BMI units compared to 12 and 13. And what's harder to follow is the lower recidivism rate, because you do not see as much adaptive thermogenesis. And Andres has really talked about that the resolution of type 2 diabetes, even insulin-dependent patients, ranges about 80%. And this is multi-site data from the clinical trial that was done in the United States. Again, we alluded to the concept of speaking about GERD and gastroesophageal reflux. And I think this is a great segue as to staging sounds better. It's like the equivalent to colostomies when I was in residency. It sounds great at M&M, it sounds great at a meeting, but in real life, I would take a step back. The incidence of GERD that we saw in the US trial with SIPs is very low. Why? They don't regain weight as much. And this is an operation that, again, you could have some bile reflux, although the pyloric presents. And I also have to tell people that the biggest inhibitor of bile absorption is fat. So that what happens is a significant amount, as people adapt, of bile that's not exposed to food will be reabsorbed, which is why when you have pregnant women, you'll get calls about high bile salt ratios in their blood, which makes gynecologists worried. So the amount of GERD cases that I see in SIPS patients or single anastomosis DS patients is a much, much lower level. And this is, again, Andres presented this showing that in his hands, okay, a combined procedure reaches the same state. And again, in my cherry pick data, my graphs look exactly the same way. Here's the however, and here is the but. I see people in New York who come from sleeves. Only about 50 to 60% are candidates for SADI because so many have erosive, esophagitis and a compromised sleeve. So yes, if you took a patient and you planned it out well, then the sum of the parts may be equal. But the real life experience of people getting to the treatment that they need is going to be low. And I will say, number one, I revised the sleeve. And I think, again, re-sleeving is what Einstein once said. The definition of insanity is doing the same thing and expecting a different result. So I think there are two operations that I use. I will use a distal gastric bypass. And, I think that's one thing that I've learned from the OAGB experience. I mainly use bypass as a revisional operation. When I do, my BP limb is at least 150 centimeters to do. But then I still will probably, and I haven't studied it, have the glucose fluctuations, the risk of marginal ulcers, if it's not resected. So I think that, yes, if you plan the sleeve and go back, it seems to have an additive result. What I would question, because patients don't come back regularly, there's problems with insurance, is will people get the therapy that they might require? Again, nutritional status, again, I find to be very acceptable. It ain't perfect, okay? But here's what I will tell you. The amount of people that I have to revise for poor nutrition is far less than the weight regainers that I see following sleeve gastrectomy. So again, looking at money, getting people to eat real foods, and there are real cultural differences, and I think Laurent showed a beautiful slide of his team, but you see there's not a tremendous amount of diversity. I've discussed this with Dan Cotta. Utah is a very different place than New York, which is the melting pot of the world. But no matter, again, here's what I will say about diet, and I think this is really relevant to an Indian population. There's not one good diet, but there is really a lot of bad diets. And if we go back to eating real food that existed, which unfortunately probably takes a cost, we need less supplements, less vitamins, and we'd have better results with all of our operations. There is no good operation for a bad processed food diet. Andre's already talked about the fact that when you move the anastomosis post-pyloric, again, you see lower marginal ulcers, you see a lower amount of small bowel obstructions. And I think that this is very, very impressive data, especially when you look at the youth of this operation. I've often said that what we do in bariatric surgery is very different than what we do in other fields of medicine. In other fields, we repair or we remove disease parts. In bariatric surgery, we create a controlled abnormality. So every operation is going to cause something. When we do a sleeve gastrectomy, we're creating a tubular stomach that eliminates the fundus, which causes receptive relaxation. If the sleeve is too small, even if there's not a stricture, there'll be rapid emptying, even with a pyloric valve, high pressured system. If anything further in the abdomen raises that pressure, reflux becomes a reality. It's interesting, the OAGB was always thought about to be the bioreflux operation. People have alluded to the sleeve might be. Gastric bypass, in my mind, causes a lot of glucose variability. If we start with a disease where the problem is high insulin levels, even though overall bypass has sound data, and I use it as a revisional procedure, it can't be the ideal when glucose variability is so high. I think single anastomosis DS, again, we can discuss how long the channel should be, I think is very attractive. I think some of the stuff that Santoro is talking about really needs to be looked at in the future. For example, can we lower the risk of anemia? Because, people don't like to talk about even in gastric bypass, the anemia rate, especially of African-American females, is well above 50% in the US. Can we change bone hunger? Additionally, we have to understand that we exist in different cultures and how to make up that gap. But there's good food and bad food in every culture. What I will say is that I don't think People are talking about, well, if SADI doesn't work, expand to a DS and shorten the common channel. I would short that approach, especially as I begin looking at functional assessments. Does your VO2 max go up? Does your oxygenation go up? So here are some of my conclusions. I think that increasing glucose variability flies in the face of fact. We actually see that glucose variability is a key marker of oxidation, which causes a lot of side effects. Whether it's post-pyloric, the addition of bile, what I do see is euglycemia without insulin in the single anastomosis DS, and I really think that's really important. Preservation of the pylorus, I think, plays some role. I don't think it's the only factor, especially in limiting solid food. And I think combining a resection with a post-pyloric reconstruction really lowers your chance of ulcer and stricture. I think staging, you got to beware. It's always going to sound better than it does because of what we've talked about, the complications of sleeve, and I've discussed that. What I'd really like to do in the future, and I think is really, really key when you ask me questions, is we have to talk less about weight and talk a little bit more about lean muscle mass and body constitution. And we should look at things like VO2 max testing, which can now be done portably, extremely accurately with direct, not even indirect calorimeters. And this can show us the respiratory exchange ratio. It tells us how healthy our patients are with their VO2 max. And look at what operations are giving us function, because if you lose muscle mass, you're not making people healthy. Now, why adding the intestine works? Is it the microbiome, the thermic effect of food? Is it metabolomics? Is it an ongoing caloric deficit? I think we have to figure it out. And then that begins to answer the questions that Mohit proposed at the beginning of the program, which are, what are the ideal lengths?
Yeah.
Thank you.
There has been an emergency in the OT and Dr. Mohit has rushed into the OT.
Okay. All right.
Okay.
Moderate the next
Well,
session.
thank you.
Okay.
Thank you, Mitchell.
Okay.
Very, very clear presentation. And I could not agree with you more. I agree with absolutely everything you said. And I wrote a paper about this in 2003 saying that food that is absorbed too fast would create an endocrine imbalance between proximal and distal gut. And there is one important issue here, because it's the distal gut activity that blocks and diminishes gluconeogenesis. And gluconeogenesis is elevated in both obesity and diabetes. Gluconeogenesis is a major issue in this subject, and just ileal surgeries can do it. But commenting about your presentation, I would say that you are willing to preserve the pylorus, and I can tell you that you can preserve more than that, because you can preserve the continuity of the proximal bowel, because as the result of this surgery is purely endocrine, you can achieve the results that we have with the bipartitions are completely superposed to yours. They seem to be extracted from the same material.
Well, I think I think SASI is something that really should be studied, that people are talking about. Again, yeah. I grew up in, kind of the bypass DS type era, but I think it's really important to do, I would love, and I'm speaking to people in the US, to do a real SASI study with endoscopy, VO2 max, and things like that. I think we need to go more into function than just weight. Sometimes I see people put up a slide and they have 110% weight loss. And what the hell does that mean? So I have a cachectic scarecrow?
Oh, many diseases can make you lose weight. We are interested in losing weight with health. And
we want to lose. Our goal needs.
Go ahead.
The SASI problem is that we have to, there is an issue about bringing bile back to the stomach. And that's why I have preferred to do a 2 anastomosis bipartition instead of 1 anastomosis bipartition. And I like this nomination, 1 anastomosis, because it clears that 1 anastomosis duodenal switch, 1 anastomosis gastric bypass, and 1 anastomosis transit.
One of the things, a few points. Number one, I think, again, our goal has to be to lose fat and at least preserve lean muscle, not lose too much lean muscle. Now, obviously, that has to do with doing training and stuff like that. And we have to really begin to look at it. What I've always worried about with the multiple anastomotic procedures, and I think this really has to be said, is that the leading cause of small bowel transplant is a midgut volvulus following gastric bypass in the United States. So that to me is something, that's one reason why I never felt, for example, like DiPaolo's operation and stuff like that. So that's kind of one of the attractions away, because we really have to realize that, yes, it shouldn't happen, but it does happen. So these things are real long term. And again, they're not shown in any data.
Okay, let's proceed at this time with Dr. Amar Vinoposa. Let him give us the Indian experience with these procedures. He does both SADI and he does both BPD-DS and in Indian patients. So, Amar.
Hi, good evening, everyone.
Thank you.
Thank you, Dr. Fobi, for having me here. I am Dr. Amar from Hyderabad, and it's a very good opportunity for me to listen from eminent professors about the BPD-DS and SADI-S, who introduced these procedures to the world. So I have been practicing, I'll share my screen now. So I have been practicing SADI-S procedures from November 2013 onwards. So the topic which was given to me is whether the sleeve plus duodenal ileal diversion procedures, are they viable in countries like India, where most people are vegetarian? So here, the problem in India is compared to Western people, where their main food is protein food. I mean, like in US nowadays, they're eating more of refined foods, but generally they take more protein, like non-vegetarian food. But even in India, even non-vegetarian people, they don't take every day. They're actually weekend non-vegetarians. They'll take non-veg in the weekends or month ends, but remaining all food will be vegetarian food. If the vegetarian food is like a protein food, that's not a problem. But most of the vegetarian foods here will be carbohydrates and fats. So will these procedures be viable in India? That's the question. So these actually, I just want to tell about these procedures briefly. So all these loop modifications of duodenal switch, there's different names are there. Single anastomosis duodenal bypass with sleeve, 1 anastomosis duodenal switch, single anastomosis duodenal switch, sleeve gastrotomy with loop duodenal switch, stomach intestine pylorus sparing surgery. All these account to the same surgery, where we do sleeve, disconnect duodenum, and attach to the ileum. That means sleeve duodeno-ileal diversion. So all the names, don't get confused. I mean, I'm talking telling the participants, all these represent the same surgery, like the sleeve plus duodeno-ileal diversion procedures. So initially, when SADI-S was started, so it was started with 200 and 250 centimeters. That's like Sanchez, they like published the articles. So initially it was 200 centimeters, but then they increased to 250 centimeters because to rectify the malabsorption. And again, some other like Roslin and others, they published with papers with the SADI-S procedures with 300 centimeters and more than 300 centimeters common channel to address the malabsorption. So when I started in India, I started doing with 250 centimeters. But compared to Western people, malabsorption is really severe in Indians. Almost 40% malabsorption was there. So I stopped briefly for some time. Then I started doing with 350 centimeters common channel. So the malabsorption has come down drastically, but still some malabsorption was there. I'll talk about that later. So if you see this is a duodenal switch where we do sleeve, we disconnect the first part of the duodenum, and then we divide the ileum and attach to the duodenum directly. So this elementary limb is 150 centimeters, common channel is 100 centimeters. So loop duodenal switch is nothing but a loop modification of duodenal switch. So the procedure is same, like we do sleeve here, we do sleeve here, we disconnect the duodenum, we disconnect the duodenum. Instead of doing row and Y duodenal switch, we are doing a loop duodenal switch. And the advantage of this surgery is we can adjust this common channel. We can keep 200, 250, 300, or 350, depending upon the requirement, we can adjust. So it has that scope of adjusting the length. So the surgery mechanism is mainly, it's not because of restriction or malabsorption. So restriction and malabsorption contribution towards weight loss is secondary. It's not the primary one. So main reason is hormonal and physiological changes. By doing sleeve, we are removing the ghrelin. We are reducing the ghrelin by 80%. And because food is directly entering, that nutrients are entering into the ileum, there will be distal gut hyperstimulation where GLP-1 peptide hormones will increase. And there's no proximal gut stimulation because food is not entering into the second part of the duodenum. And biliopancreatic juices are diverted. So there are several reasons why there's weight loss. It's not mainly due to restriction or malabsorption. So when we do these surgeries in Indians especially, first thing is the surgery should work, whether it is effective or not. If it is effective, then comes to safety. If it's safe or not, then we can proceed later. So I have been doing these surgeries since November 2013, that is SADI-S procedures. I performed until now 194 patients SADI-S. And a modification of SADI-S is sleeve loop DJB, where instead of attaching the duodenum to the ileum, we attach to the jejunum. So I was doing this surgery from May 2013. I did under around 126 patients. And SASI bypass I have been doing since February 2016. I did in 142 patients. So all these are sleeveless bypass procedures. Now this sleeve, SADI-S and SASI bypass, these two are the main surgeries I do, and followed by sleeve. So in terms of weight loss and diabetes remission, these surgeries are really effective. I'll talk about SADI-S. So if you take percentage of excess weight loss and percentage of total weight loss at 6 months and 1 year, I have published one paper on the safety and efficacy of these surgeries. It got published in 2020 December. So if you see, I separated two groups. One is common channel of 2 centimeters, where I used to do it initially, and second group is 300 or more than 300. So these patients were 26. At 6 months follow-up, mean excess weight loss is 70.9%. But at 1 year, it's 100%. So here I want to tell, Dr. Roslin was telling about 110% excess weight loss. Here, when we talk about excess weight loss, we are taking a BMI cutoff point of 25. So if anyone falls below 25 BMI, then their excess weight loss will become 110% or 120%. That does not mean that they're losing more weight. Actually, they're coming below the cutoff point of 25. If you take the cutoff point of BMI to 20, it will be 90 or 80%. But if you take a cutoff point of 25 BMI, if anyone falls below 25 BMI, that means if they're coming into normal weight limit, then their excess weight loss will be more than 100. So here the excess weight loss percentage overall is 99.2%. If with the common channel of 50 centimeters, it was 101.9%. That's the mean value I was talking about. When it's more than 300 centimeters common channel, it's 98.6. There's not much difference in the weight loss, even though I increase the common channel. Similarly, the percentage of total weight loss, if you take that one, average total weight loss percentage is 41.9% in Indian patients. So in 250 centimeters common channel patients, it was 51.2, while greater than or equal to 300 centimeters is 39.8. Why I was using greater than or equal to 300 is my common channel in my patients is varying. Like some people it is 300, some people it is 350. And now for the past 2 years, I am bypassing fixed percentage rather than fixed length of, I'm not keeping fixed length of common channel. So it is variable in my patients. So, but still, even if I increase the common channel to 300 or 350 centimeters, still the total weight loss and excess weight loss percentage are really good. So weight, if you take in terms of weight loss success rate, it's almost 99 and 100% in terms of excess weight loss and total weight loss. That means weight loss success rate, we consider it as percentage of total weight loss greater than or equal to 25%, or percentage of excess weight loss greater than or equal to 50%. I took both definitions, and according to both definitions, it's really good. And we published diabetes remission in Indian patients after SADI-S. So it was published in 2021, like March. So it's at 6 months follow-up, it's 82.5% complete remission, and it's 1 year follow-up, 90.8% complete remission. So I have patients with 3 years and 5 years follow-up but like the number is still less, not that much. So I'm just collecting the data to publish that. So as far as I remember, like the remission is maintained over a period of years. And comorbid remission is also really good. At 1 year, it's almost 87% hypertension remission. Hyperlipidemia is 94%. Osteoarthritis is 77%, and OSA is 92%. So remission, our response to the comorbid condition is really good after SADI-S. So we know that in Indian patients, it's effective in terms of weight loss, diabetes remission, as well as comorbid conditions resolution. So if you take safety, so 30-day mortality is nil in my patient. And I had 2 patients with postoperative bleeding. So it's 1.18%. Both I had to do relaparoscopy and wash that one, and they recovered well. And a sleeve leak, I had 1 patient, but it's a like confined leak. So I didn't intervene. I just kept antibiotics. The patient recovered. And there was no anastomotic leak. And long term at 1 year, dumping, marginal ulcers, stump leak, or reflux, internal hernias. None of the patients have any of these problems. So it's safe in terms of morbidity and mortality. So I have like 4 patients lost life after 1 year because of different reasons. Two patients lost life because of malnutrition, and 1 patient because of alcoholic liver failure, and 1 patient accidental death. So the 2 are unrelated and 2 are related to surgery. So when the surgery is very effective and safe, why this is not popular in India? So one is mainly because of the fear of malabsorption. Whenever they think about SADI-S, they think only about 250 centimeters common channel. They don't think about adjusting the common channel to 300 or 350 centimeters. So fear of malabsorption is the one which will prevent surgeons doing this surgery. Second, it is technically complex compared to sleeve and mini gastric bypass. So those 2 surgeries are very easy. So it's very easy to learn. So this is not easily reproducible. We need some specific training for that, and it will take time compared to sleeve and mini gastric bypass. And there's a loss of access to the biliary tract. So I'll talk about each point. So malabsorption, if you take malabsorption, as I told you before, malabsorption is a side effect of bariatric surgery. It is not the primary cause of weight loss. If you bypass more intestine because of hormonal changes and because of the biliopancreatic diversion, weight loss will be more. But at the same time, as a side effect of malabsorption is also more. So as I told you, in India, most of the people are vegetarians. Even the non-vegetarians also, they'll take only a weekend, and their protein intake is less. So this is the reason why people are afraid of this malabsorption. So in mini gastric bypass and Roentgen gastric bypass, if you bypass biliopancreatic limb more than 200 centimeters, people develop severe malabsorption. But in case of sleeve with loop switch procedures, average BP limb is 440 centimeters in my patients. So the reason why we are able to bypass more intestine, if you see both 200 centimeters, more than 200 centimeters, there's severe malabsorption. But in 440 centimeters also, malabsorption is less. So most probable reason is that's the assumption, it's not proven. So preservation of pile dust, which will restrict the food going into the intestine. Second, preservation of first part of the duodenum. So first part of the duodenum, we may be preserving only 2 to 5 centimeters, but that's the outer side, that external appearance. But inside, mucosa will be convoluted. The absorptive area is really good. And I have seen my patients, I did endoscopies at 1 year. The duodenum actually, when you inflate with gas, duodenal absorptive area is really good. So that part will become more sensitive for absorption when there's a deficiency state. So calcium, iron, and protein absorption part, at least part can be absorbed here. So in SLDS, as long as you are maintaining common channel 300 centimeters and more than 300 centimeters, malabsorption is less. But at the same time, you need to see the percentage of BPL also. What we observed is if the BPL percentage is more than 55%, malabsorption is really high. So we started restricting the biliopancreatic limb to less than 55%, less than or equal to 55%. So I have been measuring the total bowel in all my SADI-S and SADI bypass patients for the past 4 years. So over a period of time, what I understood is it's not just common channel. We need to consider BPL percentage also to prevent malabsorption, because you see, surgery may be effective, but if the patient lost a good amount of weight and diabetes is really under control, but if the patient develops severe malnutrition with a lot of protein deficiency, if they are bedridden without moving, what is the point in doing the surgery? So we need to have that efficacy and safety first. You see, by doing the surgery, they should be leading a good life. So I have to keep this malabsorption also in mind when I'm doing surgery, not just, I can compromise to some extent about the weight loss and diabetes remission, but I cannot compromise on the malabsorption point. So when I start this surgery with 250 centimeters, at 1 year with 250 centimeters, albumin less than 3 gram per deciliter, that means moderate hypoalbuminemia, it's 40%. So when I increase the common channel to 300 centimeters, that malabsorption has come down to 7.14%. If you compare with the Western data, with 250 centimeters, they have only 10% malabsorption. But in India, with 250 centimeters, 40% malabsorption. That's why for some time I had to stop these surgeries, and for 6 months to 1 year to understand what exactly is the problem. So then I started doing by increasing the common channel to 350 centimeters. So in Western people with 250 centimeters, 10%, but in India it's 40%, just because they're not taking proper protein food. So when I increase that, it has come down to 7.14%. When I checked this subgroup of patients where malabsorption has occurred, even with the 350 centimeters common channel also, these patients have more than 55% of biliopancreatic limb is bypassed. So after that, we started restricting the biliopancreatic limb to less than or equal to 55%. So malabsorption has come to almost nil. For the past 2 years, I've been doing that with adjustment. So all the people will be supplemented with high dose vitamin supplement. So in fact, actually we observed increased vitamin D and vitamin B12 after surgery because of the supplementation. Vitamin A is one which has reduced at 1 year time. Iron, there's no change, and calcium is reduced. This data is published in this article. So how I address malabsorption in Indians? So one is we got protein vitamin supplements specifically prepared for post-bariatric surgery. One is all like high dose vitamins with Bariatric and Trimac-D, only 2 tablets they can take. And another is protein. So generally all whey proteins, even though they have 80% protein, because intestine is bypassed, half of that will not get absorbed. So we got a protein separate, specifically prepared with an enzyme mixed in that. That enzyme will digest the protein. It will make sure that the total protein will get absorbed. So by giving these supplements, people are not developing malabsorption. And we counsel the patients about the importance of protein diet. Even if they are vegetarian, they have to take like nuts, peanuts, dal, curd, beans, all these things. Their diet should contain this protein diet. For non-vegetarian people, like eggs, non-veg and chicken and fish, everything, every day they have to take. And follow-up is like first year, I follow up every 1 week, 1, 3, 6, 9, and 12 months. Second year onwards, every 6 months, they have to be in touch. We have a specific, robust follow-up schedule. I'll be contacting, my dietitian will be contacting. If they don't respond, we'll send WhatsApp messages. If they don't respond, we'll call them. If they don't respond again, we'll make sure that they will come. At least we can make sure that the follow-up is more. So every follow-up, we'll do blood tests, including complete blood picture, liver function test with albumin, HbA1c, and all vitamins, and ultrasound scan of abdomen to check for gallbladder stones. If we find any decreasing trend of albumin or hemoglobin, we'll counsel them, like diet counseling, that the importance of diet. And I need to stress that these surgeries, the people should understand well before surgery itself. I'll counsel every patient for 1 hour. They have to understand the importance of taking high protein diet, importance of follow-up. Only they understand, I'll do the surgery. If they're not understanding, I'll just return to sleep. And if they regain weight, I'll go for the SADI-S revision procedure. And if anyone has signs of malabsorption, I'll go for more frequent follow-ups. Instead of like every 6 months, they may have to report me every 1 month or every 15 days, depending upon the situation. And albumin and amino acids, if the protein has come to severe hypoalbuminemia, like less than 2.5 gram per deciliter, then I'll be supplementing them with albumin and amino acid injection. We'll observe by counseling them with diet counseling. If they still maintain, if they go for hypoalbuminemia still, then I'll be readjusting. So far, I had to readjust only 2 patients, like one patient with 250 centimeters, second patient was 350 centimeters, where this BPL limb was 65% in that patient. So initially, I was not adjusting the bowel length according to the total bowel length. So I was keeping fixed at 350 or 300 centimeters. At that time, one of the patients had severe malabsorption, so I had to readjust the bowel. So other patients who developed malabsorption, generally this malabsorption or protein malabsorption will occur in the first 6 months to 1 year. After that, bowel gets settled, it will get adapted. So malabsorption risk is less. So we need to find in the first 1 year where this follow-up is very important. If anyone shows signs of malabsorption, so you need to think about counseling and readjustments. So in India, one more surgery where we can, it's also a loop duodenal switch, but with a proximal anastomosis. It's called sleeve loop DJB. Both SADI-S and sleeve loop DJB, both are same surgeries essentially. The location of anastomosis will vary. Here we do sleeve, here also we do sleeve. We disconnect the duodenum, we disconnect the duodenum. Here we measure from ileocecal junction backwards to 250, 300 or 350 centimeters and take that location and anastomosis of duodenum. Here we measure from the proximal location from DJ flexure. We measure 200 to 250 centimeters. That will be attached to duodenum. So here actually like people will be afraid to bypass more than 150 centimeters because of the mini gastric bypass related problems. But because the as I told you, the average BP limb is 440 centimeters. So 200 to 250 centimeters is nothing. It won't cause any malabsorption. So I have publications on sleeve loop DJB. I have 4 publications on that. So malabsorption, like moderate albuminemia also is not there. Maybe mild hypoalbuminemia is there, but moderate hypoalbuminemia, severe hypoalbuminemia, 0 in the sleeve loop DJB. But as I told you, if you bypass less, if you leave more intestine as a common channel, some people may not lose much weight. So initially when I started these surgeries, for less than 50 BMI, I used to do sleeve loop DJB. More than 50 BMI, I used to do SADI-S with 250 centimeters. But later, when I started adjusting the bowel length according to the total bowel length, I removed these 2 names. I started using the name sleeve with loop duodenal switch with the percentage of the bypass. I call it a fixed ratio bypass. So these are the publications on SADI-S. I have one is on safety feasibility in Indian patients, and one is diabetes remission. One more is about the weight loss, which got accepted for publication in Revista Chirurgia Journal. It will be coming next month. So bowel problems, if we take bowel problems, diarrhea is one problem where in the initial 6 months period is 80 to 28.2%, 1 year is 27.1%. Surprisingly, some patients have constipation also. So as you increase the bowel length, like common channel length, diarrhea risk has reduced. I'm talking about this together, pulled up data. So steatorrhea, foul smelling gas, and incontinence, these are like especially steatorrhea and foul smelling gas, they are really serious, big problems for the patients, especially if they take oil food, chili and spice food. They're developing these problems. So we ask the people to avoid these foods, and that has greatly helped them. And these problems have come down a lot after 1 year. So people are not complaining because body got adjusted to that by that time. Incontinence is also, if they stop oil, spice, and chili, they're not facing this problem. And if anyone is facing problem in spite of using the using oil and spice, we keep the people on activated charcoal and anti-diarrheal medication. So they will respond to that. So one reason, as I told you, is malabsorption. Malabsorption can be addressed by adjusting the bowel length, common channel length. So people can tolerate that even in India. And second, and counseling them about the protein diet. Second is it's technically complex. That's the reason why it is not popular in India. I don't think it will become popular even in future also, because people they don't want to spend more time to do surgery. Sleeve and bypass they can do in 45 minutes or half an hour. This surgery takes more time. So people are not interested. Surgeons, they want to do surgery and go enjoy life. So they don't want to spend more time in OT. So it may not become that popular in future also. Main thing is the dissection around the first part of the duodenum. That's the thing people are afraid. So there are very important structures like duodenum, common hepatic artery, proper, gastroduodenal artery, common bile duct, gallbladder, pancreas. All these structures will be in the vicinity of duodenum first part dissection. So this area has to be, we have to spend good amount of time in dissecting that area. And the second is bowel measurement. It's cumbersome to measure bowel from one end to another end. Actually, for what I do is I start measuring from ileocecal junction. I'll come to a fixed point like 350 centimeters. I make a mark and I go to duodenal flexure. I start measuring from that end. So I'll be measuring from both fixed ends, not from one end to another end. So one end to another end will become cumbersome. But if you start measuring from both ends, from ileocecal junction to one fixed point and be duodenal flexure to one fixed point, it will be easy. And next one is hands-on anastomosis. This is the reason why people don't want to do these surgeries. So here I modified that technique. Like I start dividing right gastric artery to simplify the procedure. I'll show a short video about that. So this is the way I do. Generally, this is the way people will do, like Dr. Sanchez, everyone. So as I was showing that, like RGA will be here. So that will be preserved. So the pylorus innervation will be from the nerves around the RGA as well as from the nerves of lateral jet. So when I divide RGA, right gastric artery, part of the innervation of the pylorus is gone. But still, I didn't have any problems by doing so, because this surgery, I started doing this technique because even before doing SADI-S and sleeve loop DJB, I was doing ileal interposition procedures, diverted ileal interposition procedures. For those procedures, I used to divide right gastric artery, and total this segment used to be in a single line. So the same I continued in SADI-S procedure also. We never had dumping syndrome or reflux problems, because we are keeping the sleeve, pyloric antrum and pylorus and duodenum in a single straight line. So that's probably one of the reasons why people are not getting reflux. And second is preservation of the nerves of lateral jet, which will supply along the lesser curvature vasculature. So here the importance of when I am dividing the right gastric artery, you have to make sure that you are preserving the blood supply from the left gastric artery through the vascular arcade. So along with that blood supply, preserved blood supply, even the nerves will be preserved. So this is the way I do. I divide the right gastric artery so that the total segment will be freely mobile, and I can bring the duodenum, pyloric antrum, pylorus and duodenum into the infracolic compartment, and I can anastomose. The anastomotic tension will be very less, and it will be easy to anastomose. So this is my regular position for all SADI-S patients. If it is sleeve or SASI bypass, I won't use this port. I will be using only 3 ports. But SADI-S, I will use 4 ports. This is the camera port, this is the left hand working port, this is the right hand working port, and this is to retract liver as well as to assist during duodenal dissection and anastomosis. So I'll stand in between the legs of the patient. I'll just show a video, just 2 minutes video. So this is sleeve. I am doing sleeve part. So either I use harmonic or ligashore. So after finishing the sleeve, so the epigastric port is used to retract stomach. That lesser omental layer is divided. I'll mark beside duodenum, and most of the dissection will be postero-inferior. So part of the dissection will do anteriorly also. So this is the right gastric artery. I am dividing it. You can see the lymph node over the common hepatic artery. So I won't be clipping it. I'll just divide it with the harmonic or ligashore. So here, this blood supply is maintained here, all this vasculature. So this gastroduodenal artery, once this is identified, that's the end of the dissection. So after doing, don't divide the duodenum immediately, because we divide right gastric artery. If we divide duodenum, it will be freely mobile. So go to sleeve, complete sleeve gastrectomy, then come to divide duodenum. So pull the tube back, calibration tube back. This will be very lax sleeve. It's not very tight sleeve. So I divide this. So you see, blood supply is still maintained because this vasculature is still there. And I'll measure, as I told you, from ileocecal junction, I'll measure up to this point. I'll make a mark. From DJ flexion, I'll measure again. I'll make a mark, and I'll adjust the bowel accordingly. And this epigastric port will be used to retract this suture. So I'll be using like 2 layers, one external layer, one internal layer anastomosis. So external layer is seromuscular, right to left, then left to right. So first I'll finish off the posterior aspect of the external layer. Then I'll complete the inner layers from left to right, then right to left. After completing the leftover, the remaining half of the external layer will be completed. So if you see, the duodenum is still vascular. So there's no, because we are preserving this. So that's one is, so the technical aspect, once there may be a learning curve of 5 to 10 cases. Once you start doing this surgery, it will be easy. Whether you want to preserve right gastric artery or not, it's up to you. But even if you want to preserve right gastric artery, it's easy to dissect if you concentrate on that part properly. So next point is loss of access to the biliary tract. So what we do is, if anyone is having gallbladder stones before surgery, I'll do prophylactic cholecystectomy. And all the patients, even with sleeve patients also, I'll keep the people for 1.5 years on orthodeoxycholic acid, 600 mg daily. So on serial ultrasound scans every 3 months during the weight loss period, where gallbladder stones can form. So in sleeve gastrectomy, if they
Grant, we're losing you. Himanshu? Himanshu?
Hello.
Is there
Hello, are you
technical
there?
problem?
Can you hear me now?
Yeah, go ahead.
Okay. That's last two more slides only.
Okay.
We do serial ultrasound scans, and if anyone is having gallbladder stones, if they sleeve gastrectomy, if they develop symptoms, we remove gallbladder. But SADI-S, if they develop gallbladder stones, I prefer to remove gallbladder because there's no access to the biliary tract. It's not like in gastric bypass where through the remnant stomach we can go and do ERCP, but here it's not possible. So I don't want to wait until complications develop. So whether it's viable in India or not, you see, I have been practicing since May 2013 with these surgeries. All the people who underwent SADI-S, they send me more patients for SADI-S. Those underwent SASI bypass, they want only SASI bypass. So both surgeries are really good and they're working well. People are happy. They're able to maintain. And as other speakers told, revision for sleeve, it's almost 50% for weight regain. For SADI-S, for malabsorption, readjustment requirement will be 1% or 2%. So all people who develop malabsorption also, they can be rectified with proper diet counseling and proper protein supplements and vitamin supplements. So this is definitely a viable option. Only thing, the fear about the surgery has to go, and people should understand that the common channel can be adjusted according to the requirement of the people. And as long as they were maintaining 300 centimeters common channel and BP limb is less than or equal to 55%, it's not a big problem in Indian patients. And dissection is not that difficult. Once you start doing the surgeries, it'll be easy. Advantage of SADI-S is there's no at least gastric remnant, dumping is less, anastomotic complications are less because only a single anastomosis, and pylorus is preserved. Probably this role has to be known why we are able to bypass more intestine in SADI-S people, not able to bypass that much intestine in mini gastric bypass people. Thank you very much.
Thank you. Thank you. At this time, we would move on to see where Dr. Bandera is in the operating room. I told him to go ahead and start. So Himanshu, take us to the OR. And then during that, if there are questions, we might ask. Go ahead with the patient introduction.
Good evening, everybody. I would request Dr. Shashank, our consultant, to introduce you to the patient.
So today we have a 49-year-old female whose height is 150 centimeter with a weight of 104.700. Her BMI is 42.81. She is suffering from osteoarthritis, hypertension, OSA, and type 2 diabetes mellitus, for which she is on the oral antihyperglycemic agents.
Marco Raffaelli ko dekho.
Her albumin is 4.0, HbA1c is 5.8, and she has been tested negative for all the viral markers, including COVID-19. The USG showed grade 2 fatty hepatomegaly. Over to Dr. Mohit.
Okay, so good evening, everybody. I hope all of you can see me. Actually, this patient was induced a couple of minutes back, and we have paucity of time. We have already exceeded our time. So I would just introduce you to the key steps. So just wanted to inform all of you that before any case, we do intraoperative endoscopy. We never do preoperative endoscopy, and the endoscopy is always done intraoperatively. So we have already performed intraoperative endoscopy on this patient. We basically see the GE junction, the hiatus, any lesions in the stomach or the duodenum, any ulcers in the duodenum, and any contraindication to a procedure like duodenojejunal anastomosis here. After the endoscopy, I could realize that there is no such contraindication. So I am beginning with the procedure here. At first, I would like to demonstrate the port position. So we have already put the ports in. So just focus on the ports. So as you can see, we have an optical port which is 10 mm. We have two 12 mm ports on the side of the optical port in the anterior axillary line. So these are the three ports which are in the same line. There are two ports which is around a palm breadth below the subcostal angles, both on the right and the left side. And we have put two 5 mm ports palm breadth below the subcostal angles in the anterior axillary line. So we are working with total of 5 ports, and I have put a needloscopic liver retractor here. Now, can we have the inside view? So can we have the inside view now? Okay, so as you can see, I have already done a couple of steps, which all of us we do. So we basically, first mobilize our sleeve and do the gastrolysis here, and the gastrolysis is basically done leaving around 5 centimeters from the pylorus. We leave this area to preserve the blood supply to the duodenum. So that antrum area is left and the sleeve is entirely mobilized. At the same time, I have marked the bowel at 180 centimeters. As I was discussing with Mish Roslin at the beginning, that we mark 180 centimeters, and that we do with a ruler scale. So you can see that I have, this is not my graspers which I used to mark, but I have my graspers with 5 centimeters and 10 centimeter mark. So this is the kind of graspers I used to measure the limb length so that I do not have any discrepancy. So this is 5 and this is 10. And just to avoid the time, I've already measured 180 centimeters and hitched the bowel here close to the pylorus. This is the pylorus, and we mobilize the duodenum. The duodenum is mobilized around 2.5 to 3 centimeters. So this we will divide here with a white cartridge. But at first, I will try to make the sleeve. As already demonstrated, that the sleeve is made 5 centimeters from the pylorus. And also I would, when I would divide, I will also measure the duodenal cuff for you. So let me have a blue cartridge and make the sleeve. So we make a liberal sleeve here. The sleeve is calibrated with a bougie of size 38 French, but I don't think that the bougie size makes a lot of difference, because that's just for the calibration, just for the maintenance of patency, pardon me, not for too much for the calibration. Usually our standards for doing this kind of a procedure are fixed. The volume of our sleeve is around 150 to 180 ml. The length of our sleeve is around 18 centimeters and the breadth is around 2.5 to 3.5 centimeters. So this area is around 2.5 to 3 centimeters, very wide at the incisura, no narrowing, no chances of the stricture or anything. And I'm using a blue reload here, and just using the bougie of size 38 French here to maintain the patency of the lumen. And as you can see, I'm not going very tight, very snug to bougie, just leaving that space and basically giving 2.5 to 3 centimeters and a little liberal pouch here. This is not too much of restriction. Unlike the sleeves which we make, which are very, very tight, with a lot of closeness to the pylorus, I leave usually 2.5 centimeters from the pylorus. And the reason is that we make a little tighter sleeve, which a volume of 80 to 100 ml. Mostly our sleeve volumes would be maximum 110 ml in most of these cases. But here it's a little liberal because we have given some malabsorption. I would say not malabsorption, I would say hypoabsorption of around 180 centimeters. We don't count the common channel like Amar does, because Amar takes a very small common channel. I believe that if the length of your total bypass in any sort of these procedure, whether it is MGB or whether it is a SADI-S or whether it is a gastric bypass, the total length is less than 200 centimeters. In 99% of the cases, we realized that the common channel is almost more than 400 centimeters. So that's not going to cause any sort of problem in our set of patients. So this is a sleeve. I have some little bit of oozing here. So usually I think we can make this oozing will settle with the clips. I'll put a gauze here so that by the time I do my duodenal anastomosis, most of this oozing stops. I usually put some clips if there is a little bit of oozer which I feel can spoil my field. So something like this. Diffuse ooze, I usually put a gauze and I wait. Most of them would resolve. But sometimes there is some ooze which can spoil my field. So I don't suture my staple line. I usually use clips. In most, 99% of my procedures, we very liberally use these clips and we are able to stop this bleeding. This patient is a very hypertensive patient. Our blood pressure is around 150 every time we are operating. So I expect a little bit of oozing here. Even before, when this patient was intubated, I had to request Professor Phoebe to introduce Amar because this patient started oozing because during the gastrolysis. So I had to rush back to introduce. When my fellow was mobilizing the greater curvature of the stomach, so I had to rush back and do that. This patient is a little hypertensive because of the metabolic disorder this patient has. We are operating at a little supranormal blood pressures here. The anesthetist is doing the best of the job to bringing the blood pressure down in this particular case. So at this stage, I would just wait for the oozing to settle down. The gauze will do its job here. I can come back and have a look again, and if I feel like I may even use some more clips, but I'll just start to do my main step, putting the gauze here so that we take care of the diffuse oozing when the and most of the times this stops because can we remove the gastric tube, please? So now we have the sleeve made, and as you can see, I'm coming to the, can I have the endo stitch? I'm coming to an important step where we have already mobilized this part of the duodenum, and if you can see, this is our pylorus here. So I'll take a ruler scale and measure for you. Now, before I divide this, some important tips and tricks. So the first trick is we don't mobilize this here around 3 to 4 centimeters, at least 5, to preserve the blood supply. And then we make a plane from here along the greater curvature and create a plane between the pancreas and the posterior wall of the stomach. If there is some oozing, like that time there was oozing, I just put a gauze like this. Can you see? I just put a gauze and left it. And now I hope that by the time I remove this gauze, all the oozing from this plane, from the pancreatoduodenal arteries would have been settled. So I just very, I'm very cautious here because we have pancreas here. And whenever there is oozing, like it was there when I was dividing it, for which I came inside here to help the team, I just put a gauze and came out. Did nothing, absolutely nothing. And you see, by the time we have reached now, everybody should appreciate that there is no oozing here. So this is taught to me by Professor Antonio Torres. I was doing a case when he was here in Indore, and me, myself, and Professor Phoebe, we invited him, and there was some oozing while I was operating, and he said, just do nothing, just put a gauze there and come out, and most times you would see that this oozing stops. So you can see now I have a good cuff of duodenum here. I take mostly, so this, if you see, this is the pylorus here. I will measure it for you. It's a good 3 centimeters of a cuff which I have, and I don't want to go more distal because I don't want to, reach closer to the other vital structures. But this is good enough structure for me to sort of do an anastomosis. So I have a good cuff now. I can start to do my posterior layer. As I said that I already took a hitch here, 180 centimeters. And now what I can do is I can pull this structure here. So what I'll do, I'll give me a harmony. I'll just do a little bit of release from here, a very small release, just because I don't want tension to be there on my anastomosis from here. And when I do this, I'm very, very cautious that I do not damage any important vital structure. Okay, so now I have not too much of a tension here on my anastomosis. So I'll take it here, and the trick here is to go posterior as possible, because now you can see this is the exact anti-mesenteric border. So I'm going to go here, take a little thicker bite, and then this is the fourth layer which we are trying to take. So So you can see that this is the staple line. I'm going to go here so that I get a good cuff to take the second and the third layer. And here also you can see that I'm going very flush to the anti-mesenteric border.
Any panelists has any comments or questions they can ask at this time or make the comments?
We were commenting with Dr. Pernotti the tunnel dissection versus the pyloric dissection. So I see you like the pyloric dissection that I feel gives a bit more. Sorry, you like the tunnel dissection. I think moving the whole greater curvature past the pylorus give you a bit more length of the on the duodenum. So I'd like to know what's your preference.
Yeah, I was mobilizing the entire length, like you said, but we had some cases where we had a dusky duodenum, and I was a little scared.
Okay.
So I just, I just thought to leave that area because, and we have done both these cases. The advantage, as you said, is very clear. We get a very mobilized cuff.
Mm-hmm.
And here the cuff is a little stuck, is what I can feel. But it's okay. I mean, this, you can see the duodenum is not as dusky. And this assists in, later on when I'm doing an anastomosis, it assists in a much better, it assists in much better vascularity. So that's
All
the right
is still
gastric, not completely, not
Okay.
completely, a part of it, not completely. Okay, so now I have this layer, and now I'm going to use my harmonic to make a gastrotomy here. So you can see I hold the staple line and we expose this completely. And I'm just going to go with my shear half the harmonic, and I'm going to go in that direction. And this gives a good feel to me that I have entered inside. And then I go straight until this edge. Okay, so now what we can do a suction, and I can demonstrate where my pylorus is. So you can see the pylorus there, right? That's the pylorus. And I am not damaging the pyloric sphincter. And here, this area, I'll open a little bit more, just a little bit, so that I gain a good amount of size of my anastomosis. This is good for me. I'm going to open here a little bit, just a little bit here, so that I have a, okay, so this is fine for my stomach, and that's the pylorus. As you can see, that area is the pylorus, this here. So I'm going to stay away from that, and now I'm going to open the bowel. Now the trick here is, whenever we open the bowel, we always open it a little smaller than the stomach. So again, the same way, I enter here, and exposure is the key. So I exposed it, and then we just stretch it. And always it has to be seen and reassessed while we are opening it, so that we don't open it in an unusual fashion where it is sort of non-uniform. So you can see I started from here, and I'm going to just keep it a little smaller because this dilates because of the carboperitoneum with time. So you can see that this is here, and then I'm going to hold this and stretch this. We'll assess it again. whether that's enough for me. So I think I'll be able to manage with this kind of length. If you stretch it, it's good enough. So
Yeah,
now
that's good.
I need my endostitch device. So what is the trick? We enter here inside and then I go outside from above, but I try to remain close. So this is the stitch, which is an important stitch. And this stitch, if taken, correctly and close to the area of the anastomosis, you can see I'm not too far away from both the edges, just close to it. And I can now start to take the third one. So that's fine. Now I can take the third one. So this is here. Now I would enter inside. So you can see I just put my suture and I enter here again inside from the edge only, so that I just take nice corner. So this is a well taken corner. Now I know that both these edges are there. So with one of my graspers, I can just, so I want to make sure that I have taken both the layers. So now I would demonstrate. So this is the first layer and that's the layer on that side. So I want to take the stomach and as well as the bowel equally. So this is there. At the same time, I'm sure I have a full view of the pyloric muscle. So I know that I'm not taking the pylorus anywhere and not obstructing it. So you can see a very nice suturing can be done. An endostitch is a good device here. It's handy because you need not write your needle every other time while you're taking the layers, and it saves a little bit of time. So this is here. Now I can come out again through the edge. So I'll take one bit here. And now, I can come out. Now again, the trick is to come out just through the edge, not go too far off. So this is my small bowel and I just come out from the edge here. And then I again enter it through the gastric reservoir, through the edge, so that I've secured the corner towards the side of my stomach. So that takes care of the third layer and I can cut it from here. And maybe I can take one more and cut it, and then I can start all over again from the other side. So that's it. I can cut it here and then I can start, and that could be my final layer. The second layer could be my final. I need not take the first one to even give it a cover if I'm satisfied. I'm not saying that I would just check. Usually we don't, because we are satisfied and we are using the staple line to give a cover here. Usually we do not in our technique. Now again, I need to make sure that I have gone beyond my anastomosis, and this is just a serosal cover I'm just giving to just complete this anastomosis. At this stage, it's beyond the gastrotomy enterotomy complex. I'm pretty sure, because that's the suture stay. Okay, so now I can just use my staple line here to give the strength to this anastomosis. So you can see that's why I kept going a little posterior, and that's why in this particular technique where we have to take a little bit good amount of cuff so that we can use the posterior area, posterior to the staple line. And this is a little what I wanted to demonstrate. If we keep the blood supply intact, we don't see a lot of duskiness. Although, even if we have a little dusky sort of the duodenal cuff, I have seen with the passage of time, once the carboperitoneum is gone, I've seen that duskiness settling back beautifully. So not an issue, but what I would want to demonstrate is that when we do it, we are more confident when we see nice blood supply, so that there is no chances of future stricture or anything. As you can see, I'm using the staple line here to give protection to my anastomosis. And that's why I don't take a first layer again to cover this. But I'm very sure that this is good enough for an anastomosis to be leak proof. So you can see how I am using my suture on the other side to retract and triangulate. So you see, I can pull it here, I can pull it on that side, and that's the beauty. And my assistant can basically follow the suture for me because my other hand is completely blocked. At the same time, my bites are good and thick because I took it a little posterior to the, I'm close to the anti-mesenteric border. I have a good amount of bowel here left. The lumen anteriorly, I'm not very concerned about the lumen anteriorly. So that's it. This is my, I would say, penultimate stitch. And just one more to complete the anastomosis to cover this corner. So I see this here. Okay, I can just tie it here. Can I have a needle holder? So I can give me a needle holder. Endoscope. Okay, so I can now cut this and then I can obviously do a nice endoscopy for all of you to demonstrate how the anatomy looks from inside. This is my anastomosis here. So as you can see, it's a, this is the afferent limb and that's the efferent limb here. And this is my sleeve. So I'm going to come in with an endoscope to demonstrate that I can pass in through the efferent limb. And then I can answer if there are questions which are there. So can you just focus on the endoscopy now, the camera? Can we have the endoscopy here on the? Okay, so that's the esophagus. I'll ask my assistant to just take in a stapler so that he can block the front end so that I don't have the bowel all dilated. That makes the patient a little uncomfortable. Although this is carbon dioxide, it gets absorbed. But I'm just going to ask my assistant to block. And as you can see in the PIP view, now this is the esophagus. I would enter inside. That's my G junction. Here, the Z line. Now, this is my stapling, which I did. Little bit of oozing here, just fine. I'm okay with the internal view. And now here I enter inside. So that's the area. Okay, so this can be a little difficult because we have to manipulate the scope through that area. So I'll give it a try. If I'm able to, I'll do it. Otherwise, I'll put in a regular bougie to negotiate. So till here, we are fine.
Right there. That's a Polaris.
That's my pylorus. So if you can see, I'm actually at the pylorus. So this is my pylorus here. Let me try for some time, otherwise I'll put in a bougie. Okay, can you help me with your scope? So you can just okay. Okay, so now you can see that I entered in that area, and I'm not gonna force too much because this is sort of a fresh anastomosis.
Yeah.
I'm just gonna, okay.
You went
So-
through already.
Yeah, I'm through already, but I just want to negotiate through. Okay. Okay, so I'm distal to that area. And now I'm not gonna push in too much because you can see the air in both the limbs. I'm just
Nice
gonna
fit.
suck the air.
Yeah. Good.
So it was this area which was a little here where our scope was sort of angulated, so it could not be pulled through. Thank you very much.
Yeah, I went through, so it's patent. Okay. Any questions or comments? Somebody says, somebody has the hands. Okay. No questions. Okay. Marco, do you do anything different in the anastomosis?
Yes, I usually perform a posterior dissection, complete dissection, and perform anastomosis with conventional stitches, not using the
In the
bend
stitch.
stitch tool. I usually use the staple line as the extend for the posterior
wall.
layer. Yeah.
Okay.
But it's similar the amount of dissection. As I prefer to have a complete opening of the posterior surface of the duodenum in order to have an easier for me stapling of the duodenal cuff.
Okay. All right. Like you said, we're running at least 30 minutes longer than we planned. Mohit, can you make a concluding statement and then we'll go from here?
No, thank you very much for coming. I think we have exceeded our time. I just thought to shorten these steps. As Marco said, we were also mobilizing the entire part, but I'm concerned about the vascularity, so I leave it there. Most times, even if we mobilize it completely, we can get away with it, but sometimes I'm bothered about some leaks or something. Thank you very much. I have no additional comments to make.
Okay. Thank you all very much.
Congratulations for the section, and thank you again for inviting me.
All right. Thank the faculty, thank our participants, and thank the staff at Mohawk for another nice webinar.